Hello and welcome to the CRRT documentation guide on EPIC for UK healthcare. My name is Brian Klein. I'm a CRRT nurse educator and I've served that role since 2019. The intention of this presentation is to be a comprehensive guide for documenting CRRT. It's basically the worst day that you could ever possibly have with a patient on CRRT, where you would encounter a multitude of situations that you'd have to document. Hopefully you will never in your career have to do all of these things in one day on one patient, but if you do, we got you covered. This presentation will cover a variety of topics, including a brief introduction to charting on CRRT, starting therapy and charting the first few hours on various ultrafiltration goals. We'll have a little section on how the flow sheet actually works for you nerds out there. We'll talk about how to chart when you've gone off therapy temporarily and getting caught up when you're behind, overriding the actual bounce, which is a very useful knowledge to have, and some frequently asked questions. So we will start with a brief introduction to charting on CRRT. This is pretty universal for pretty much anywhere you're going to be, but specifically for UK healthcare, we have some specific needs. You may wonder why CRRT documentation matters, and there's a variety of reasons. We need it to look at the correct dosing for pharmacotherapeutics, because different types of clearance will have different ways of changing your pharmacokinetics, and the charting will illustrate which one you're currently on. It will help the nephrology team monitor the performance of their prescription and whether they need to increase or decrease your effluent dose or move it from more convection to more diffusion based. It's going to help with proper billing, because in healthcare nothing is free. It's going to help us track metrics to target for quality improvement. If you can't measure it, you can't make it better. But most importantly for you as the nurse, it's going to help you calculate the proper patient fluid removal to achieve a proper patient fluid balance. Many patients who come into critical care are resuscitated with volume, only to have that same volume contribute to mortality later on. So CRRT is going to help reverse the tides on that. I will be the first to admit that charting on CRRT at UK Healthcare can be a little bit challenging. However, most people find that when they practice it a little bit, it starts to get a little bit easier. There are a couple principles, though, that will make your life a lot simpler. First of all, only document 1 hour at a time. I cannot say this enough. You may hear this multiple times throughout the rest of the presentation. Also, if you don't have your intakes and outputs correct, you're never going to get good CRRT information. Try not to overthink it. Let the flow sheet do the heavy lifting for you. All you got to do is document the numbers. And if you ever get stuck, remember there is row information for almost every type of row in CRRT. You may have to unminimize it in your sidebar. However, it's going to be a big advantage for you. Alright, so what are the actual charting expectations for CRRT? This is all coming from policy NE 08-06. Pretty much, CRRT charting is hourly. That's going to include the treatment status, which is the type, current status, whether it's running or not running, and the filter type. It's going to include the fluid balance, and this is really the heart of why you do CRRT charting, which is the goal, intakes and outputs, and any corrections. Nurse maintenance activities, such as the machine number, deaeration chamber status, your warming device, your fluid temperature settings, and almost all patients will have some sort of external heating device, whether it's the Thermax or a bear hugger or an Ultrix blanket. And then the machine parameters, which is going to include all that stuff that you usually auto-enter. Sometimes it will not, though, and it makes it a little bit more cumbersome, but it's not that bad. In addition, make sure to remember to do your vital signs and your intakes and outputs hourly on their respective flow sheets. All patients on CRRT need hourly temperatures and vital signs. As needed, you'll chart the additional items anytime that you change your filter and the reason why, and you only chart it when you change it. The cosigner for any filter or prescription changes, and an attestation that hematocrit was entered and the machine number was entered with AM Labs. The machine number that you'll chart is the big black number on the front left portion of the machine. Most of them are just a number. Some of them have the letter M in front of them. Note that it is not the 20. That is referencing the 20 ml heparin syringe. The machine number will also be in a label maker on the left-hand side of the machine. It's a lot smaller. There is no machine 20, so there's no confusion. Alright, so the main heart of charting CRRT is fluid balance. This relies on you having intake that's documented hourly. This is going to include anything from your IV pumps, tube feeds, free water, including your med flushes. People often forget about that. Output is going to be hourly or according to your nursing judgment. So if you have a urinary catheter that's making 50 cc's per hour, you're going to make sure you get that every hour. If you have a chest tube that's only putting out 1 or 2 cc's every hour, you might wait a few hours because that would drive you crazy trying to do that every hour. Every time you return blood to your patient from the CRRT machine, whether it's for a saline recirculation or a filter change, that is an intake. Because you are returning the patient's own blood, yes, but you can't take the saline that you used to prime the machine back out of the patient. So that's a net intake, and that gets charted as CRRT flush fluid. Every hour, you're going to also chart the patient fluid removal, which on the flow sheet is called actual fluid removal. If for whatever reason you have your machine set to 0 and it gives the patient back 1 cc, you can put 0 in the flow sheet. But remember, the machine should be following the orders that nephrology wrote. If you are unable to, say, pull net negative because your patient is extremely unstable, have that order updated, because especially with recent Joint Commission concerns, we want to make sure that we are pulling according to our prescription. There are 3 orders that can be placed, 3 different types of orders for ultrafiltrate removal. The first one is 0. This is when you set your patient fluid removal, or PFR, to 0. This should be fairly rare because we only want to do this for patients who are extremely unstable, or on the other hand, we might have people who we pulled a little bit too much fluid on a couple shifts before, and they may change their order to 0 to let them rebuild. Net even is the next type, and this is when we basically want to add up all the fluid we're putting onto our patient and all the fluid that's coming off our patient naturally, so if it's a Foley catheter or an NG tube, etc., and then we split the difference with the patient fluid removal. So this one involves a little bit of math, but let the flow sheet help you. And then the last order is net negative, and this is when we are trying to take off the surplus of fluid that most patients have built up, and that's the whole reason that they're on CRRT. So this is when we're going to pull a little bit more fluid than we are putting in them. Remember, do not confuse 0 and net even. They are often confused. The machine will never allow you to give your patient a bolus through the machine, right? Because you wouldn't want to give your patient a bolus of Foxillum, for example. However, it does not know what the Alaris pumps and the Kangaroo pumps and all the other things are putting into your patient. In a perfect world, we would always take off exactly what we wanted to from our patient according to our prescription and goal, but obviously that world doesn't exist. We usually end up taking a little bit less than we need, or sometimes a little bit more than we need, and this creates a running deficit that needs to be accounted for in the next few hours or next many hours. So for example, if your patient had 175 milliliters in and you pulled 160 on your CRRT machine and your goal was to be even, you have created an hourly deficit of 15 cc's. And this is a pretty tame example. Usually it's a lot more than this. This is why the flow sheet is important to do correctly, because it allows you to chip away at that running deficit slowly and gently over the coming hours. And it may take an entire shift or entire 2 shifts to get caught up from the running deficit, and that's okay. CRRT is all about slow and gradual. Let's start our fictitious day as our patient Edna comes up from the ED at 7:23, and we're going to start her on CRRT at really close to 8:30. In looking at our orders, we have the mode of continuous veno-venous hemodiafiltration, or CVV-HDF. The filter type for most adults is going to be the ST150. Patient fluid loss or gain limit is 400 milliliters over 3 hours. Now this is often confused with our ultrafiltrate goal, but this is an entirely different concept. The patient fluid loss or gain limit is basically the machine allowing itself to run correctly. If it detects an increase in any of its scales or a decrease by 400 milliliters in a rolling 3-hour period, it will shut off. This is really important because if you have a bag clamped, it's not going to lose the weight that it needs to as that fluid is pumped into the set, and in the patient side, the PFR pump, the yellow pump, is going to take that fluid off and pull way too much, because again, the machine is not going to take off any more than it puts on, but it can't take off fluid that it never gave. So this is just a safety feature. You really don't even have to change it. The blood flow rate, or BFR, 150 milliliters per minute. Note this is in mils per minute, not mils per hour. The rest are in mils per hour. Our UF goal, which in this case is net negative 0 to 100. What it's really saying is even to net negative 100, but the way that the prescription is written, they can't really put two different types of goals. Temperature setting is 37 degrees Celsius. The pre-blood pump is going to be 300 mils per hour, and that's citrate. The dialysate pump is going to be Foxilum 4.0 at 2,000 mils per hour, and the replacement is going to be Foxilum 4.2.5 at 1,000 mils per hour. Now, how does this actually look in Epic? Well, if you go to your specialty orders, this is where the CRRT prescription is. You can see everything that I just said right here. You're not going to see the fluids, however, that's going to be in the MAR. So here they are in the MAR. I have it filtered by continuous up there, as you can see. Note that since this patient's on citrate, they're also going to have a calcium infusion that's going to go on a central line elsewhere on the patient. It's not going to go into the CRRT machine. If you go to the PRN tab, you'll also see the priming fluid, whether it's normal saline or heparinized normal saline. In order to get a CRRT machine from Agility, we enter the order CRRT machine. This can be entered under pretty much any provider. I usually do it under the first call provider. Per protocol, no cosign required. When you put the order form up, it's going to give you three options. Bring machine, which is what we need now. There's also a return machine option for when we're done with therapy. And then there's a third option called exchange current machine for new machine. That's if our machine were to break and we needed a new one. I like to put the room number in the blank spot on the right there just to help them find the room, but this will print a paper off in the Agility office, so you don't really need to. Now, when we start CRRT, we want to make sure that we clear all of our pumps and make sure that there's no remaining fluid from the hour before we start CRRT. Otherwise, when we do our first hour and we clear the pumps then, it'll look like that patient got in 1.5 liters of various fluids, and your goal is going to be completely worthless. So if you haven't been data validating beforehand, and since this patient came from the ED, they may not have been able to data validate, you're going to go ahead and do that now and clear all of your pumps, your kangaroo, your IVs, etc. And we're going to chart that for 8 o'clock because that's before CRRT starts. It's not going to count against us. In charting our first filter change, we're going to go to the CRRT flow sheet and we're going to go down to nurse maintenance, and under filter changed we'll say yes, and the reason why is initiation of therapy. We're also going to put the machine number and all the other things there. I am the primary nurse, so I put my own name under the sign off primary RN. However, my co-signer, who's going to verify orders with me, she should badge in to her own Epic and find my patient and place her own name on the secondary RN. This way, when you look at the value information in the audit trail, it will show that she was the one who put her own name there. This way, my license is covered and it shows that I didn't just put some random person's name there. For this first initiation of therapy filter time column, there will be no fluid balances to chart because this is hour 0, minute 0, so just leave these blank. So let's go for the first few hours of CRRT and show how to pull fluid on 3 different UF prescriptions: net negative, even, and 0. We're going to cover the standard workflow of the hourly charting. There's general themes of hourly documentation. First of all, it's a 1, 2, 3 workflow. So do your vital signs, including your temperature, your eyes and O's for that hour and only that hour, and then your CRRT flow sheet for that hour, and again, only that hour. It's really important not to chart the eyes and O's for multiple hours and then try and do CRRT for each individual hour, because the way that the flow sheet works is it looks back to the most recently documented time column in the I know flow sheet. The vital signs are pretty self-explanatory. You just chart them, including the temperature. If your patient does not have a temp sensing device, such as a temp sensing Foley, which most patients probably shouldn't because they're not making much urine, or perhaps a rectal probe or esophageal probe, you're going to need to do an oral or axillary temperature. We're going to do the second step, eyes and O's, by clearing all of our pumps, or now that we have Alaris Epic integration, data validating those pumps. Make sure that you remember anything that's not in scope, such as blood products, some medications like methylene blue or various chemotherapy agents you will have to chart manually. But the flow sheet is pretty good at pulling those numbers through and getting an educated guess. If you need to clear things physically, we have a worksheet that you can use to kind of keep your brain together. And since we've gone live with the Alaris Epic integration, I have noticed quite a few people still using that. I don't know if that's out of habit or if it's still very helpful, but this is a tool that you can use. Obviously, it's not part of the chart, and you just shred it at the end of your shift. If this is the first time your patient is getting CRRT, and for Edna it is, you're going to have to add a couple rows to your I know flow sheet. We're going to add the CRRT intake row for any time we need to return blood, and the CRRT output row for our hourly patient fluid removal. When we go to the I's and O's, we are going to go to the top, and there's a little arrow that you can click, and it takes you straight to Infusion Verify All. And I really like this because it will only do Infusion Verify up to the time column that you have selected. Otherwise, you'll have to uncheck a lot of things in future time columns, and no one wants to have to do that. Note that we've already entered our PFR under the actual fluid removal from CRRT. So here is our Infusion Verify form. You'll notice that it is snapped to 0900, so we don't have to uncheck any extraneous things that happened after 0900. Just remember that you want to make sure you only do this 1 hour at a time. So if it's been 2 hours, we would only do 9 o'clock at this time and not proceed to 10 o'clock. The flow sheet does not understand that citrate is a non-intake. It basically treats citrate like an IV fluid, unlike the Foxellum. So if your patient's on citrate, you may have to click the little blue box where the volume subtotal is, kind of where I've indicated with an asterisk. And then where it opens that box, the interval volume will be 300. Just delete that and write 0. Now we're going to go to our CRRT flow sheet. We're going to start with the treatment section, and our treatment is still CVV-HDF. It is now continuous instead of initiated, and we're still using the ST150 filter. We're going to select the appropriate UF goal for the patient. Since our order was 0 to net negative 100, we are going to go with 50. This is a clinical decision that you will make as the nurse. If your patient's doing really well and you think you can get all 100, I would go for all 100. If your patient's kind of so-so, as Edna is in this case, we might go for 50. And if you're really not sure at all, you might go for the lowest range of your goal. Just remember that you're always entering a singular number in there without a negative sign. If you put a negative sign, Epic will try to add that to your goal instead of subtract it, and it will miscalculate, and your flow sheet will be wrong. If your goal is 0 or even, you'll just leave the goal desired net fluid removal blank. All right, now we are to the fluid balance portion with the intake and output. To get these numbers easily and quickly, we can go to our sidebar summary and select the hourly intake and output activity, and it will open a table, as you can see on the right, and all we need to do is transpose the total intake for the hour and the total output from the hour into those two slots. Anywhere that you see a double dash means that no data was entered. So as you can see, this patient was on D5LR in the ED, but that is no longer running, so it's okay that we have that double dash. But if that were, say, her norepinephrine or her propofol or something that we know is still running, this would be our time to say, hey, wait, I know that I forgot to enter a value. Let me actually clear this out and go back to my INOW flow sheet and fix it. So what about midnight? For people who work night shift, you will not have the sidebar summary for 1 hour of your shift from 23:01 till midnight, because the sidebar summary only does the current calendar day. And of course, you'll be charting midnight for technically the day before. So in order to get these numbers, don't do math. We don't want you to have to do any math. Go to your summary, not your sidebar summary, but your actual summary activity. And under the intake output tab, you can select a table option and do it by Q1 hour. And you can see I've circled the 2 numbers that you need. So it's just 2 numbers to remember to go over to the flow sheet. All right, so we continue on and we let the flow sheet do our numbers. It's going to calculate your deficit from prior hour, which doesn't really mean anything for this first hour because we just started. It's going to carry over the PFR, or actual fluid removal, from CRRT on your INO flow sheet. It will calculate your actual balance, and it will calculate suggestion based on the goal you entered. We're going to then continue to chart our nursing maintenance. We're going to do our machine number, We're going to look at our deaeration chamber for clots, make sure the blood level is correct. We are still using our fluid warmer, which is the Thermax at 37 degrees, but we do not need to chart, and we should not chart filter change again because we've already done that. We'll then finish by auto-entering the machine parameters. This is going to come from plugging your CRRT machine with a Ethernet or Cat9 cable from the dongle that says Prismax directly into the capsule. In future software, this may be available to come through auto-enter through Wi-Fi, but we do not have that as of now, and I'm recording in February of 2026. In this particular example, I was using the playground, so I don't actually have the patient weight balance or cumulative value to enter, and that's okay. If you don't have auto-enter, just don't worry about those. Okay, so we did our first hour of CRRT charting. Let's pretend that it's been an hour, and now we're going to chart 10 o'clocks. Edna's not doing so good, so we have called nephrology and asked them for an even UF goal, and so they've changed our order, and now we're going to do that. So we are going to start by doing our eyes and nose and our PFR. We've data validated all of our pumps, and we're ready to move on. Now when we get to the flow sheet, we start off doing the same things with treatment, but when we get to fluid balance, this time we select even as our UF goal, and we leave the goal desired net fluid removal blank because the flow sheet knows that it has to basically make eyes and nose match for even. It runs the numbers, we use our sidebar summary just like we did for intake and output, and it comes up with a suggestion based on this new goal. Now let's fast forward to 11 o'clock. Let's say Edna's really not doing good. We call nephrology again and get them to update our UF goal to 0. And this should not happen that much in real life, but just pretend for this example. We've done our INO flow sheet already, just like we did before, and this time when we put in the hourly UF goal of 0, it doesn't really matter what we put in because the flow sheet will suggest 0. That's our goal. For anybody out there who's a bit of a nerd, and I totally include myself there, this section kind of shows where Epic is getting its numbers from. Feel free to skip this if it's a little too much. I think most people probably will find it that way, but if you are a nerd like me, stick around. So the row names there's a lot of different names for the row names, but they all have a specific meaning. The hourly UF goal, everybody probably knows, that's the goal that's set by you based on nephrology's orders. The goal desired net fluid removal is going to be blank if your goal is 0 or even, and if you have a net negative goal, you're going to put a single positive number. Patient intake, all intakes from that hour, pulled from the sidebar summary. Total output is all outputs for that hour, also pulled from the sidebar summary. Patient balance is basically saying how much that patient got in versus out if they were not on CRRT. So it's actually going to, we'll show this in the next slide, but it's going to show that you have your intakes minus your outputs plus the CRRT PFR back. And that'll make sense hopefully more in a minute. Deficit from prior hour is what you didn't get off on the prior hour based on your goal. It carries it forward to this hour. Your actual fluid removal from CRRT, this is the same thing as the PFR on your machine. Actual balance is going to be your patient balance, so that's your balance this hour, plus your running deficit from the prior hour. So this is where we start to get that cumulative aspect that's really important for the flow sheet. Override actual balance is when we need to basically change that actual balance for various reasons, and we'll talk about that more later. And then the suggested fluid removal next hour is your actual balance plus your goal. So let's see the math on that the next slide. So row A, you select that, and that's hourly UF goal. The goal desired net fluid removal, you select that. C and D are the intake and output that you enter. Now here's where the math starts. The patient balance is going to be your patient intake minus your total output plus the patient fluid removal on the CRRT machine. So basically that's answering the question of what would this patient be, either negative or positive, if they were not on CRRT. Row F here is the deficit from the prior hour, so that's going to be your suggestion from the prior hour minus your actual fluid removal for the current hour, so basically what it's carrying forward the last hour. G is going to be your PFR, that's carried over from your INO flow sheet. Your actual balance, which is row H here, is going to be your patient balance plus the running deficit. I is the override actual balance option, and you only use that if you need it. And then our suggested fluid removal next hour, which is J, is going to be your actual balance plus your goal, right? So if your goal is 50 and your actual balance is 100, that means that it's going to suggest for the next hour that you pull 150. And that's why the goal desired net fluid removal has to be a positive number. Let's talk a little bit about going off therapy temporarily and how to keep our flow sheet working and also minimize the workload to ourselves. So let's say that Edna has a CT at 9:15 and it takes until 10:05 to get back. So we have an hour of quote-unquote missed charting at 10 o'clock. So what do? Just run the numbers like you would if you were still on CRRT. It's very important that you still do your eyes and nose for 1 hour, do the CRRT flow sheet for the corresponding hour, and then go back to the next. Otherwise, it will be wrong. Note that fluid might build up while you're gone because you're obviously not able to pull fluid, but that's what CRRT is all about, is you can slowly chip away at it when you get back. So in the example we're about to show, we returned our blood and did a saline recirculate while we were gone. So first, at 9:15, when we disconnect, we're going to document that we are off CRRT in our status row and that we're recirculating. There's no fluids to chart for this because we are not on CRRT, so you just leave the fluid balance part blank, and you also really only want to do those fluid balances on the hour. Otherwise, it's going to be really pretty much impossible to keep track of if you do like 59 minutes worth of CRRT. Now at 10 o'clock, we're still off CRRT, and it's recirculating while we're down in CAT scan. But we're going to run the numbers just like we did before. Now, we're obviously not going to do this in real time while we're in CAT scan. This is going to be after the fact. So at 10 o'clock, we pull all of our numbers through our Alaris pumps, the ones that we are able to get, and then we do our CRRT flow sheet for that hour for fluid balance. But notice that we're not charting any of the nurse maintenance stuff because we're not actually on CRRT. At 10:05, when we come back, we'll chart initiated under status. And we're not going to chart fluid balance because, again, the fluid balance should only happen on the hour. Note here that we are charting again our machine number and attesting that there's no clots, etc. So now that we're back in the room on CRRT at 11 o'clock, we're back on track. Notice that our suggested fluid removal has bumped up a bit because we returned our blood, which counts as a net intake while we were gone. That's kind of a plug for if your patient can get away with it, and making sure that your pressures aren't too high, and especially if you're on citrate, you might consider a blood recirc instead. Remember though, only chart your eyes and nose 1 hour at a time. So let's say you don't get to chart any of this until 11:30. You would chart your 10 o'clock eyes and nose, and then your 10 o'clock CRRT, then your 11 o'clock eyes and nose, and then your 11 o'clock CRRT. In this example, we're looking after the fact at what we just did. So you can see that at 9:15 we left for CAT scan. Again, there's no fluid balances for that time column. At 10 o'clock, we note that we're still off and recirculating, and our fluid balances are present because we're running the totals, even though we're not there. At 10:05, we reinitiated, but there's no fluid balance because, again, we're not on the hour. And then at 11 o'clock, we are back doing our regular thing. Note that there is a little bit of PFR carryover in all of these time columns, which is why it works to chart them on the hour even when you're not doing the CRRT actively at that time, because you're carrying those balances forward. So kind of in the same vein, let's talk about getting caught up when you've been behind on charting. It is 1 o'clock and my patients got really sick and I got super busy and I wasn't able to chart again until 4 p.m. How can we do this without breaking the flow sheet? It's just like we did when we went to scan, except it's a little bit longer this time, but it's the exact same principle. You put in your eyes and nose for the most distant hour, so in this case it'd be 1 o'clock, then do CRRT flow sheet for 1 o'clock. Then back to 2 o'clock for eyes and nose, 2 o'clock CRRT. 3 o'clock eyes and nose, 3 o'clock CRRT, 4 o'clock eyes and nose, 4 o'clock CRRT, done. Back on track. Do not enter all the time columns at once, because then the CRRT flow sheet will only calculate based on the most recently documented time column, which is 4, and it's going to undo all of your work from 1 to 3 from a documentation standpoint. So even though you couldn't clear your pumps while you were running around like a chicken with your head cut off, those are able to go into Epic because of Alaris integration. Now, if you don't have Alaris integration on whatever drip that you're running, you can clear that pump and divide it by 3, or you can just put 0, 0, 0 for those time columns until you actually do get to clear your pump. So for example, tube feeds, that would be what you'd have to do. So as I kind of mentioned in the previous slide, you do everything for 2 o'clock on I's and O's, then 2 o'clock CRT, 3 o'clock I's and O's, 3 o'clock CRT, 4 o'clock I's and O's, 4 o'clock CRT. Is it tedious? Yes. But will it work every time? Also yes. Let's talk about override actual balance, because this is a very important feature. Edna, our patient, is having a really bad day. She gets a big bleed and she needs a massive transfusion protocol, or MTP. How can we give her all this blood without getting a flow sheet that is now suggesting that we pull that entire volume of MTP? Let's take a look. Other cases where you might want to override the actual balance is when you have unwanted intake, so that'd be an NTP. And when I say unwanted, I mean you don't want it to interfere with your CRRT values. Or if you have an unwanted output, like a paracentesis or a thoracentesis. You may also want to do it if you're giving fluids that you don't want to remove, like burn victims. I've had patients where they were on a maintenance fluid drip that they knew was just going into chucks, and so they didn't want us to remove that on CRT, so this is how you would fix that. And you can also use override actual balance to fix an error in the flow sheet that you wouldn't want to go back and have to recalculate all those time columns. Times when you do not want to override the actual balance, you don't like the suggestion because you're like, that's too big, I don't want to do that. Or if you just give a little bit of blood for hemoglobin replacement and not volume expansion, this is a case where you would do nothing. You would pull off that volume because the patient needed the hemoglobin molecules, not the physical 300 mLs of volume. How do you do actual balance override? All you do is you take the actual balance for that hour and you add or subtract the amount desired from override actual balance. So let's see these in practice on the next couple of slides. Let's first talk about that MTP, where Edna got 1,425 mLs of fluid of quote-unquote unwanted intake. You can see that the suggestion, if you run your time column as you're supposed to at 5 o'clock, is 2,066.5. Obviously, we don't want to pull that, and we don't want that to count against us. So in order to fix it, we will type the actual balance minus the unwanted intake to fix. So in that case, it is 2,066.5 minus 1,425. When you hit enter, it will do the math, and it will change that to 641.5, and in doing so, it will update the actual balance on your flow sheet. So essentially, it's unlocking the row that's locked for you to type over it. So everything's fine, we've done our MTP, and we've calculated everything we needed to. As far as unwanted output, it's the exact same thing, except this time we're going to use a negative number and add in the unwanted output. So if you do the paracentesis example here, where they took off 5 liters, you can see that when you run the numbers, it gives you a suggestion of negative 4,417.4. Obviously, you're not going to give fluid back to your patient to erase that negative running deficit. So what you're going to do is you're going to put the actual balance in, which is negative 4,417.4 plus 5,000. Or if you want to think of it as minus a negative 5,000, minus a negative is positive. When you do that math and you hit enter, it will change it to 582.6 and update the actual balance to that number. So once again, we fixed our flow sheet. Now let's look at how we can use override actual balance in fixing a small mistake. So it is 7 p.m. and we realize, oh no, at 12 we gave Edna 150 milliliters of free water in her Dobhoff. We're going to go back to our 12 o'clock time column on the I's and O's and chart that, so it occurs at the quote-unquote correct time, but it will not update our CRT flow sheet because those columns have already been charted on. So what we're going to do is at 7 o'clock, we're going to add that to our bill, so to speak. We're going to type our actual balance for that hour, which is 518, plus the 150 that we need to put on our docket to pull in future hours. And once you hit enter, it will change it to 668. Okay, so that was a small mistake. Let's look at how we might fix a bigger mistake. And this is a hypothetical because there's so many different ways this could go. So let's pretend that nurse before us had a net negative goal of 50, but they put negative 50 in as the goal. We know that that is going to push our numbers in the wrong direction because it's going to subtract that number from our goal instead of adding it. So what we're going to do is we're going to take 50 times 12 to get rid of that accidental adding of 50. And then we're going to do it a second time so that we're out of the negative numbers into the positive numbers. So what you're going to do is you're going to take 50 times 12, do that times 2, and that ends up being 600 mLs. So as you see on our screenshot here, our actual balance is negative 954. We're going to add in the 600 plus the next 600 to get back to the negative goal, and so that's 1200. Once you hit enter, it's going to change that to 246. Anytime that I see a negative number in the suggested fluid removal, I immediately kind of think, have we accidentally put in a negative goal for our UF goal? Because it's just pretty rare for people to pull too much fluid on CRRT. Definitely does happen on occasion, but it's not the norm. Usually we're behind instead of ahead. We have saved Edna's kidneys somehow. And we're going to chart how we stop CRRT when we're not restarting. First, we're going to show that we return blood, because if possible, we'd like to return the blood when we change a filter. That's a volume of 217. We kind of talked about this earlier, but again, even though it's her own blood, it is a net intake, because we can't take the saline that we use to prime the filter set out of the filter to return it. We have to actually give more saline to push that blood back into her. You can see at 1845 we have created a time column and our status now says off and we return blood. And there's no fluid balances that we need to chart because we're done. So if you want your flow sheet to look better and for it to not confuse future treatments, just type in 0 for override actual balance and it will clear out any remaining fluid. It is obviously great if throughout your entire goal your actual your running deficit is exactly 0, but we know that that's not reality and almost no patients will actually be perfectly at their goal when they're done, and that's okay. I reserved this last section for questions that I'm frequently asked. People always have questions that aren't here as well, so feel free to email me and I can add them to next version. So the first question is, why does the CRRT flow sheet need to only be 1 hour of data at a time? And long story short, Epic is really good at math. It is not good at thinking. Maybe in the future AI will be able to do all this work for us, but at this time you still got to feed it the data the way that it wants, and it wants it hour at a time. All right, next question. My suggested fluid removal is large, my patient's unstable. Should I just plug that number into the machine's PFR and hope for the best? No, please do not do that. We want you to pull based on what your patient tolerates. If your goal is net negative 200 and your patient's adding a fourth pressor and they just look terrible, don't pull that amount. We need to pull based on what the patient is actually getting. How much is too much PFR to do in 1 hour? There is no right answer for this. I've had patients that we couldn't pull any more than 50 cc's per hour. I've had patients where we were able to pull 450 and they were perfectly fine for an entire shift of that. Typically those are bigger patients. But things that you should look for are new onset hypotension and conversely a significant elevation in pressor requirements. Any new tachycardias, particularly atrial dysrhythmias, can be hints that we're pulling too much from the intervascular space and that third space fluid is not moving in fast enough to replace it. If that happens, people will often ask, am I pulling too much? Should I just turn my PFR off? We really don't recommend doing this. We recommend cutting it in half and kind of watching your patient over the next few hours. I will tell you that if your patient is unstable from hypotension, turning your PFR completely off won't fix that anytime soon anyway. So that's why we suggest cutting it in half and watching them. We also want to make sure that we're not blaming a new sepsis or another cause of hypotension on the CRRT machine. If your patient's bleeding into their belly, it might look like you're pulling too much fluid, but then when you cut your PFR off, you're going to find that their patient doesn't really get any better. So make sure that you look for other causes. Next question. My hourly UF goal is net negative 50 to 100. Does that mean I can never pull more than 100 mils net negative? No. The hourly goal is supposed to be an average. If the nephrologists want to pull, for example, total of about 10 liters off your patient in 4 days, when you divide that out per hour, that ends up being about 100 mils net negative per hour. Some hours you might be able to pull a little bit more than that, and a lot of hours you may not quite be able to pull that much. Remember, CRRT, it's slow and gradual, and sometimes it can be discouraging because you want to just do everything perfectly, but our patients don't always follow that same time scale. So make sure that you pull based on what your patient is tolerating, and if your patient does tolerate it, maybe you can pull a little extra. Next question. My patient is maxed on 4 pressors, their lactate is climbing, and your UF goal is pretty ambitious with a net negative 100 to 200. What should you do? Don't try and pull that, but don't just ignore it either. Call nephrology, or your primary team can call nephrology for you and get them to update that UF goal. We obviously want to do something that is safe for the patient, but we also need to follow our orders, especially with Joint Commission. All right, if I forgot to clear my pumps for an hour or I got busy, how can you fix it? There's a section that we already covered called getting caught up when you're behind. Next question is, what if I have a bunch of fluid coming up that you know that you're going to need to pull, like a amphotericin B, or maybe just anything that's a large volume? You can definitely pull ahead as long as your patient tolerates it. And if for whatever reason that antibiotic gets canceled or discontinued, you might pull a little bit less than your goal and let them catch back up. Where can I go for more information? Well, we have the CRRT SharePoint, which is pretty much everywhere on the SharePoint, everywhere in your new hire information, but if you want to type in the address, it's right here. If you have any questions, like I said, I can be reached at brian.klein@uky.edu. And thanks for watching this.